I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Welcome to another episode of Women's Health Unplugged. I'm Dr. Jordan Robertson. I'm a naturopathic doctor in Ontario and Canada, and work almost exclusively with women in the perimenopause and menopause phase of life in my personal clinical practice. But I also own a large naturopath-focused multidisciplinary clinic that has practitioners that focus on all areas of your health, whether it's digestive health, fertility, cancer recovery. We actually have someone for everyone. But I wanted to focus today on a symptom that often comes up in the perimenopause-menopause transition, or maybe it's a symptom that I would say psychologically has really significant distress associated with it. We're going to tackle hair loss. Now, this is not an easy symptom to treat in clinical practice. It's a toss-up whether hair loss or weight loss is more challenging to support patients with. And I think that's probably for a couple of reasons. Hair loss is hard to assess. So if you're at home and you think you are losing your hair, or you think your hair is thinner than it used to be, like the research suggests, you're probably right. And I know that doesn't feel very good to feel like you need the research to validate the way that you feel about a symptom. But sometimes we don't have a great grasp on how our symptoms are showing up, or how we experience our symptoms from year to year, whereas hair loss is one of the ones that patients are actually relatively in tune with. And so from a clinician standpoint, if our patient says that they have hair that's thinning, we should just believe them. And we don't really need to do a whole lot of, we call it prospective tracking, meaning like, you know what, let's just watch your hair for 6 more months and see what you think. We actually should take your word for it if you feel like this is something that has affected you, or it's starting to, become a problem for you. We should just believe you, and we shouldn't just watch it over a period of time. So, but it's hard to assess hair loss, and part of that's because it can be impacted by lots of factors. It can be impacted by mechanical stressors in your day. I remember my hairdresser, who I love, was like, "What are you doing? What are you? There's this patch of hair that's like traumatized in the front. What are you doing? And then she was like, "Are you wearing a sleep mask?" And she was right. Like, I had started wearing a sleep mask at bedtime, and the rubbing of the sleep mask on my hair was actually causing mechanical damage to my hair and breaking the hairs off. And so I perceived it as like a whole bunch of little small hairs that were growing, but they actually were longer hairs that had been broken in half because of the rubbing of my sleep mask. So we can have mechanical forces that will change hair. That could be like changes to your ponytail, changes to the way you style your hair. We can see changes in that shedding fluctuation based on styling, brushing. If you don't wash your hair for many days in a row, then you may experience more shedding in a brush when you finally do wash and brush your hair. And sometimes if patients have lifestyle adjustments or changes that they haven't really thought of, the way that might impact their perceived shedding, patients can feel like they're shedding more when turns out they're just wearing their hair curly with a spray in sea salt spray, which I love and I do. But then that means if you don't brush your hair for the sort of 4 or 5 days, that when you do, you might get this perception that things are really falling out when really maybe they're not. So it's hard because we want to just believe you and you say that your hair is falling out and it's falling out more, but we also need you to understand that there might be things going on in your day-to-day that have influenced the way you're feeling about your hair fall. If you change your pillow or pillowcase, that might influence how many hairs are on your pillowcase in the morning. Even seasonally, we do see some fluctuation in hair fall seasonally. But let's assume that none of those factors are part of it for you, but you're still noticing that your hair is shifting or changing over time. So where should you start and what should you do? And really the focus or goal for today is that I wanted you to feel empowered about getting assessed and actually starting to notice things about your own head and your own hair that you may be able to communicate with your practitioner. And to advocate for the kind of testing that you might need in order to start to get to the root of the hair loss problem. And I think this is why clinically this is something that's so challenging to manage, because by the time we meet a patient who's struggling with hair loss, they've brought it up to their doctor, they waited 11 months for a dermatologist referral. That dermatologist was like, nah, I don't really know if there's anything we can do for you. Or we call it genetic, or we call it stress related, which that's not that validating. And then finally, by the time I see a patient, she's really struggled with her hair loss. She's devastated about the lack of support that she's received. And then when we walk through options and assessment and treatment, it really just never really meets anybody's goals or anybody's expectations. So part of why I want you to have this information at your fingertips is that if we decrease that diagnostic delay, we may be able to help you out a little bit more, help you feel a little bit better about your journey. And I want you to understand what your treatment options kind of might look like, or how to ask about treatment options and what to expect with various treatment options. There are multiple reasons why we lose hair. And really, when we do any kind of testing in patients, it should be to see if we can find the underlying cause of their hair loss, or maybe give us some direction around how we would possibly support patients with hair loss. Hair loss is a symptom, right? It's not really a diagnosis. It is a symptom that we're observing in you. And we can see hair loss happen in many different ways. There's pattern hair loss, which in the past was maybe called female pattern hair loss or androgenic alopecia. They're trying to have a bit of a glow up on that, where we're calling it a little bit more accurately just female pattern loss or patterned hair loss. And that kind of hair loss is typically on the crown of the head or the top of the head, where the back of your head might be spared. So you have really nice thick hair at the back. Sometimes women will experience that as noticing that their part is getting more defined, or almost we call it a Christmas tree pattern in your part, where the hair on the crown of your head is thinning so much so that if you part your hair down the middle, you can see the sort of this visible, your visible scalp in your part. And female pattern hair loss or pattern hair loss is primarily genetic. It does happen to almost all people with age to varying degrees. So it's really rare that someone throughout their entire lifetime is spared of some hair thinning. We believe there's a hormonal drive to that, but it's interesting. We don't actually always see hormone levels be abnormal in patients who have pattern hair loss, even though we think hormones are part of the problem, which you can see why that creates so much uncertainty around testing. And we'll talk about hormone testing in a minute. But that's one type of hair loss that you may experience, sort of top of the head, patterned hair loss. You also can experience diffuse hair loss all over the head. We typically will call that in the scientific literature telogen effluvium, or TE. That's the kind of hair loss that you might have been heard referred to as like stress-related hair loss. And that's where hair is shedding at a rapid rate all over the head. So it's just as likely to be at the back of the head as it is to be at the front of the head. Hair does go through natural growth cycles. So the hair follicle goes through a long anagen phase, which is where the hair is growing. And then there is a loss phase, and then there's a quiet phase of each of those hair follicles. And each of these varying types of hair loss will move hair, more rapidly through that growth phase into the loss phase. And that's where we experience that significant amount of shedding. And then in some types of hair loss, the quiet phase of the follicle ends up getting lengthened, meaning that the hair doesn't regrow as fast as we would maybe expect it to. And so that's where we see this like excess loss, right? If lots of hair moves into the losing phase or the shedding phase, but then the hair follicles remain in a dormant phase, that's where we end up with the thinning aspect of hair loss. So telogen effluvium is like all over hair loss, general thinning. So your whole ponytail maybe is thinner. This is where you may experience like rapid shedding, where you find it like in your brush or on your pillowcase, for example. And if you really like kind of grabbed any 50 or 60 hairs all over your head and just kind of gently pulled, you're going to pull out maybe 4, 7, 8 hairs at any location on your head, right? Because it's kind of all over. Then some patients will struggle with alopecia areata, or they'll lose a circle of hair completely where that entire patch is missing. We believe that that's actually autoimmune driven, although our understanding of that particular kind of hair loss right now is not amazing. Actually, all of our understanding of hair loss is not amazing. Again, I think this probably is why we feel a little bit disappointed in how we support this symptom. But alopecia areata, we generally think there is a big connection to the immune system. If we biopsy patients with alopecia areata, we see inflammation and white blood cells infiltrating the follicle. We do think there's an autoimmune component, and we tend to see it a little bit higher in patients who have other established autoimmune disease, whether it's vitiligo or celiac or Hashimoto's thyroiditis. Lots of patients who have alopecia areata will have spontaneous grow back. So their hair will just like come back all of a sudden. But lots of patients don't have hair grow back in those patches, or it takes a very long time for those patches to start to regrow hair. So there are other kinds of alopecia that cause more permanent damage to the scalp, but these 3 that I've just labeled there are non-scarring forms of alopecia, and in theory could maybe be reversible. Now, not always, right? Again, it depends on when you seek care and what the underlying issue is and how genetic this is for you versus environmental. But in theory, all 3 of these types of hair loss would maybe be something where we'd have a little bit of wiggle room on trying to support that patient journey a little bit. So we certainly can try and figure out what type of hair loss you have based on where you're losing it, right? Is it the top of the head or the back of the head? Is it a patch? And your history sort of leading up to when you've experienced that hair loss. So like I said, with age, it's hard for people to be spared for not having some hair thinning with age. That really changes our questions about hair loss if the person who's sitting across from us is 27, right? So we wouldn't expect that person to have hair thinning quite yet based on age, and so we'd want to look for another reason, right? But just talking to someone about the pattern of their hair loss and when they've noticed it, where it is on their body, if their scalp has any associated symptoms, whether it's itchy or painful or burning. There's some medications that will cause hair loss. There's some other medical conditions that are associated with hair loss. And so really part of that assessment needs to be a thorough history taking. For female pattern hair loss, we're more commonly going to see other hormonal concerns in that patient. So acne, irregular menstrual cycles, maybe infertility, definitely patients with PCOS or polycystic ovarian syndrome. 20 to 30% of patients with PCOS will have some hair thinning on their head. And so that's maybe our most common route that we're going down if we're thinking that patients are having that female pattern hair loss, especially if they're under the age of 45. If patients are over the age of 45, we might not see any changes in their hormone levels, and we may be starting to call this, and I'm using air quotes, and I hate even to say that anything is age-related, but we may be seeing this age-related progression in the way that your scalp responds to testosterone or the health of the scalp and follicle with age. And we're starting to see that female pattern hair loss start to approach in that perimenopause, menopause age and stage. So that history-taking purpose really is to help us try and figure out the path for where you got to where you are right now, and then to help us understand how to do some further assessment. So the testing for hair loss, there's a few things we should do in everyone. There's a few things that we should do based on what we're noticing about you, okay? And again, I think this is another point of maybe dissatisfaction or frustration when patients are getting assessed for hair loss, is that we seem to take this kind of stepwise approach with assessment that can leave people feeling like, well, let's try this, let's try this, let's try this, let's wait for this, without fast and furious answers, right? But that said, we also shouldn't like needle in a haystack your health. Really, like if you've had that good history taking done, like I said, some tests should be done in everyone, but some tests maybe should be done based on the type of alopecia or hair loss you're experiencing, your age, your stage, etc. So the things that we should be testing in everyone, okay, is looking at some of the nutritional deficiencies that have been really associated with hair thinning or alopecia of multiple types. Okay, and so the two that I would maybe call as a standout would be iron deficiency and vitamin D deficiency. So both iron and vitamin D are required or necessary for hair growth. They both have receptors or purposes at the follicle. And hair is actually one of our most rapidly dividing cells in our entire body. That's partly why they're influenced so much by chemotherapy, or some types of chemotherapy. And so the nutritional building blocks that we would maybe need to have rapidly dividing cells like iron and vitamin D, it kind of makes sense on paper why we would see a deficiency of those nutrients being associated with poor hair growth, hair loss, or struggling with regrowth after you've had loss. So iron, we know that when we look at patients who have all different types of alopecia, the likelihood of patients being diagnosed with iron deficiency is actually higher than the average population. So if patients have no hair loss, their likelihood of having iron deficiency is X. If you have hair loss, your likelihood of having alopecia is significantly higher than that. Patients who have a ferritin of less than 15 micrograms per liter are actually 2 times more likely to have hair loss than patients who have a ferritin over 15. And truthfully, like 15 is not a number that we should really be celebrating. But there's lots of patients that walk around with a ferritin of 14, 15 that we maybe wouldn't raise our eyebrows at. But we probably should, because from a hair loss perspective, that's having a significant impact on the likelihood of having hair loss. And there's lots of studies and really recent studies that have looked at this as well. Ferritin, actually, when we survey physicians, that is the number one blood test people get sent for when they do have hair loss. So this isn't something that you need to, beat your doctor's door down over. They're the most likely to order this test out of any other test. I think what I want patients to take away from the iron conversation, and we've talked about iron on the podcast a lot of times before, is that our concern around numbers is probably warranted, because what we would maybe consider to be fine on paper may not be optimal from a hair perspective. So there are multiple studies that have looked at what our cutoffs maybe should be with hair. And although we can't find this perfect number to say, well, above this, your hair will be beautiful, and below this, your hair will fall out, it does seem that using some cutoffs that are closer to 40 for ferritin gets us closer to helping prevent that increased risk of hair loss. Now, on lots of laboratory measures, 40 is well inside the reference range, where the bottom level of the reference range might be 12 or 15 or 20. So you do need to look with a more critical eye at your results to make sure that we actually get you into a range that is more acceptable. We've also looked at, there's some interesting research that has actually tested iron in patients that we didn't bother testing iron on, and we still find iron deficiency in patients that we didn't think they had iron deficiency just based on what they said. So there was a study that looked at hair loss patients, and they basically added iron assessment to their blood test after their doctor had assessed them. So there was a group of patients that weren't tired, maybe didn't have heavy menstrual bleeding, and their doctor didn't think to order iron. And then the research or the lab actually checked off iron to see what they would find. And they found additional cases of iron deficiency, even in patients who had no other symptoms. So what I want you to take away from this is that if hair loss is your only symptom testing your iron is still incredibly relevant, even if you don't present as that stereotypical iron deficient patient, okay? And if your iron was fine 2 years ago, but your hair loss is now, I still would recommend that you get your iron tested. It's the number one assessment we should consider for patients with hair loss. The other one being vitamin D. So vitamin D, it's this kind of the same conversation. So patients who have low vitamin D have an increased risk of presenting to their doctor's office with hair loss. And we think the numbers for that one is actually relatively accurate. So you don't need to look for a number better than average. I just would like you to be inside the reference range. But we do see when patients have either genetic challenges with vitamin D or very low vitamin D, like rickets, that there's a loss of body hair. So it seems to move patients into that, it seems to move patients into that hair loss phase, and we can't move into the growth phase if our vitamin D is low. Okay. And so those are the two tests from a nutritional deficiency perspective that I would consider. You'll find articles that talk about B12 and all sorts of other nutrients. But the vitamin D and the iron are the ones that are the most significant. What I wish we had was better research on what happens if we fixed it. What I want to know is if we fix your iron, what happens, right? And there's a little bit of research that does talk about that path to improvement of hair loss if we solve your iron deficiency. But the research really has focused on if you're low, you are more likely to have hair loss, both for vitamin D and for iron. The next blood test that I would consider having done would be a thyroid panel. And this is mostly because hypothyroidism, like a symptom of hypothyroidism is hair loss. And that the kind of hair loss that we experience with hypothyroid is that all over hair loss. And so different than maybe with hormonal, like testosterone driven hair loss, where it's like the top of your head, the hair loss that we have with low thyroid, we do see as like an all over hair loss. Now, when you get your thyroid assessed, it's almost, you need to have like one additional test done. So yes, frank hypothyroidism will increase your risk of hair loss, but also having autoimmune hypothyroidism or Hashimoto's thyroid will also increase your risk of hair loss and different types of hair loss. So that more alopecia areata, where we lose like the coin shaped or patches of hair loss on your head. So when you go and have that thyroid panel done, it really needs to be a bit more comprehensive than just the one test that we typically see from a public health perspective. Yes, if you have flat out hypothyroidism, it's a problem. But if we start to see some autoimmune tendencies in your health, that may guide us a little bit around how we support you from a hair perspective and from a future health perspective. And kind of when we find those antibodies, it almost like opens Pandora's box, meaning that we often will see autoimmunity come in clusters in patients. And so then we really should screen you for celiac, right? If your thyroid antibodies are elevated as well. So that's one, and I'm not going to say a whole lot about the thyroid. It's really almost a yes, no on that one. Like, is your thyroid contributing to your hair loss as a symptom of hypothyroidism? And especially for my patients that are moving into that perimenopause, menopause stage of life, we do see big changes in thyroid economy at that time, right? Because of the changes we have in our female sex hormones, it puts some pressure, we'll call it, on your thyroid economy, meaning that your thyroid hormone levels often also change in perimenopause. So again, if this all over hair loss is new, that would be something that I would throw on the requisition to be assessed for. And I would include the antibodies, mostly so that we don't have to send you back to the lab again later. And then the last test that I would consider to have done with respect to your hair loss would actually be to be screened for celiac disease. And this is mostly if you're experiencing that patchy hair loss or that alopecia areata. But if you have any other skin symptoms, if you have any digestive symptoms, if you have any genetic tendency towards celiac, it's just a great rule out strategy. It's interesting, the time to diagnosis for celiac is really long, meaning that patients will suffer for a long time before someone goes like, hey, maybe we should look for celiac. And so using hair loss as this impetus to drive patients into the lab, I actually still think is a really positive thing. what I want you to take away from that celiac piece there is that if the answer is no, you're not celiac, you don't need to follow a gluten-free diet for your hair loss. And if you Google hair loss diets, you'll see gluten-free mentioned a lot of times. Really, the only time that we see a significant improvement with gluten-free and hair loss is if patients also have celiac disease. So what about hormones, right? Like I mentioned at the beginning that hormones are related to that patterned hair loss where we're losing the hair at the top of the head. There's pros and cons to testing hormones. Okay. So in a young patient where hair loss is part of their whole experience of their symptoms of menstrual irregularities and what have you, I think testing hormones can be quite a valuable way of us understanding their underlying diagnosis, meaning maybe they have PCOS. And if that's the case, we likely would see elevated total testosterone. We may see other hormone changes depending on whether or not patients are ovulating regularly. And we may see elevated levels of DHT or dihydroxytestosterone in the blood, although that's a bit rarer. And we may see elevated levels of DHEA, which is another androgen that's produced in the adrenal glands. These are the things we might see in patients that have hair loss at a young age and menstrual irregularities, acne, etc. Now, as patients age, their blood testosterone levels do go down. So sometimes we can't find elevated testosterone in patients who we thought were a shoo-in for having high testosterone based on their acne and their hair loss because there's an age-related decline in testosterone. So you might look normal on paper, even if, at a time, maybe your testosterone was elevated in your blood. The other challenge that we have is that blood testosterone levels are not a great reflection of scalp sensitivity to testosterone, meaning that your hair follicle might be wildly sensitive to testosterone, but your levels are actually normal. And we do see that this is where we think that genetic tendency towards patterned hair loss is that it's in the sensitivity of the follicle to DHT, not that you have like terrible high amounts of DHT necessarily. But sometimes testing hormones can be valuable for patients, and I would say that one needs to be done on a case-by-case basis. What I want you to understand about that, though, is that if your hormones come back normal, that doesn't mean that testosterone isn't causing your hair loss. And it doesn't mean that maybe you could pursue some anti-androgen solutions or testosterone-lowering solutions for your hair loss, whether that's the oral contraceptive or spironolactone or finasteride or some of the testosterone-blocking medications can be supportive for androgenic hair loss in women, even if their testosterone levels are normal. And so it's this testing piece. Like the testing is not the end all be all when it comes to that patterned hair loss for patients. Testosterone goes down with age. It doesn't give us a really good assessment of what's happening with your scalp sensitivity to testosterone. And it doesn't mean you don't qualify for treatment options that might support testosterone. And so you can see why I maybe wouldn't be jumping the gun to do major hormone assessments in patients with hair loss, because especially over the age of 45. It's different if you're younger. If you're younger, we're probably going to find it, or we may find it, and it may influence like your whole health plan, not just what we do for hair. So I'm a bit more of an advocate of testing hormones in a younger population because it's part of a bigger conversation with hormones than it is with patients that are slightly older. But those are the big tests. So yes, there's other things that can be screened, right? Like I mentioned, there are the rarer causes of hair loss, whether that's lupus or some of the autoimmune diseases can definitely cause hair loss. And you would maybe consider adding some of those tests to your requisition if you had symptoms that maybe were leading us down that path of looking at autoimmunity, whether that's joint pain or other rashes, etc. But the major list that I want you to focus on if you're struggling with hair loss, and this is hair loss of all types, is going to be iron, it's going to be vitamin D, it's going to be a thyroid panel with antibodies, it's going to be a celiac screen, especially if you have alopecia areata. And you may or may not consider running your testosterone levels depending on your age and stage and how much that's going to influence our choice with respect to treatment. And just to reiterate there, the vitamin D and thyroid, I'm going to call that a yes-no, meaning that if it looks fine on paper, it's probably fine. Whereas the iron, we're going to be a little bit more picky, and I probably would want to see some of those numbers be a little bit better than what we would typically flag as being deficient or sufficient on a lab test. I want your ferritin to be above 40 if you're struggling with hair loss. And for some of you, that's going to take some heroic conversations and solutions with your practitioner, because as a menstruating person, it can be really hard to get your ferritin levels up that high. The last piece I want to say about hair before we head out for the day is actually around just satisfaction with treatment. And I want to have deep empathy. I shouldn't say I want to have deep empathy. I have deep empathy for patients who are looking for support with respect to their hair loss. And part of the issue is it takes too long for us to diagnose you. We often shrug our shoulders and call it stress, which might be true, but that's not that validating. The solutions that we offer improve hair loss. And in the research, we're looking for a 50% improvement in your hair loss or your hair regrowth, whereas patients are looking for a 90% improvement in their hair loss or hair regrowth, right? And that makes sense that we have those expectations. If you remember yourself having this beautifully thick head of hair, that's what you want to go back to. The challenge is that we call it clinically successful if we get 50% of your hair back, and that leaves patients feeling like their treatment's not working or their practitioner's not listening. And I think that's actually just a communication error, right? If we helped you understand that there is some change in hair density as we age, there are some genetic factors that are going to influence your hair journey, and some of them we can overcome and some of them we can't. And the ones that we can overcome may never get us back to, I think about my daughter's head of hair. Like, I want my 12-year-old head of hair. We may not get to be able to move to that space of hair density, hair thickness, volume, growth, etc. in later stages of life. And that communication can actually be quite freeing for patients, similar to the acne conversation, where maybe your hair loss is something we manage, maybe it's something we support. I'm not sure it's something we cure in every case. And if we can help you find the most appropriate, the best solutions for you, but also help you understand what our limitations are from a medical perspective, I think that's probably where we achieve the absolute best outcome for you. But if we don't have good communication, if we pretend that there is a 100% solution right around the corner and you just have to find it, it really makes patients feel quite shameful about their experience of hair changes. When there are some hair changes that are going to happen with age, I would absolutely love for you to get that lab work done, so we felt like we truly understood the impact of your hormones and your nutritional status on your hair. But I also want you to have lots of compassion around the impact of your hair loss journey on your psychological health, and to make sure that you feel really well connected in that hair journey with your practitioners, so that everyone's on the same page and everyone feels like they're on the same team. I hope you enjoyed that episode of Women's Health Unplugged. We're changing things in women's health. One episode, one topic, one conversation at a time. I want you to feel confident in your health. Please remember that the podcast does not constitute a medical relationship or medical advice. Please talk to your family doctor, your practitioner, your specialist, or anyone on your health team if you think some of the topics we discussed in today's episode apply to you. Take care of yourself. Until next time.